Good afternoon, everybody. Welcome to today's webinar. My name is Dr. Sandra Friedman. I'm Director of JFK Partners at the University of Colorado School of Medicine. Today's topic is Fragile X, genetics, clinical insights, and interventions. Please feel free to type questions or comments in the chat at any time. Captioning may be accessed using the Zoom function at the bottom of your screen. We ask you please keep your microphone muted so we don't hear background noise. We're recording today's event, and this recording will be archived on the JFK website. In addition, we will post the presentation slides that you're welcome to print or save for future reference. Following the webinar, you'll receive a link requesting an evaluation. You may request a certificate of attendance of the evaluation as well, in the evaluation as well. So we really like receiving your evaluations because they help us with future webinars. I'm really excited about today's speakers. Today we're going to have Dr. Nicole Tartaglia and Susan Howell talk about Fragile X. Dr. Nicole Tartaglia is a developmental behavioral pediatrician and professor of pediatrics at the University of Colorado School of Medicine, and she is within the section of developmental pediatrics. She directs both the Fragile X Clinic as well as the Extraordinary Kids Clinic at Children's Hospital Colorado, specializing in Fragile X syndrome and sex chromosome disorders. In addition to providing her wonderful clinical care for Fragile X families, Dr. Tartaglia leads research on Fragile X as a leader in the CDC-led, CDC-funded study Fragile X Forward project, and she also leads many different clinical trials for the treatment of Fragile X syndrome. Susan Howell is a board-certified genetic counselor specializing in Fragile X. Since 2008, Susan has served as the genetic counselor and clinical coordinator for the Fragile X Clinic, as well as the Extraordinary Kids Clinic at Children's Hospital Colorado. She plays a key role in clinical care, research, and education, as well as co-authoring national guidelines for Fragile X genetic counseling. She's served on the board of the National Fragile X Foundation since 2023, supporting families and advancing awareness and research. I've heard both Susan and Nicole speak, and they're wonderful presenters, and I know you're going to greatly enjoy this webinar and learn a lot. So thank you for joining us today, and I will turn it over to Nicole.
Hello, everyone. Thank you for coming. I'm just going to share my screen and get everything loaded up here. Okay. There we go. Okay, so we appreciate everyone coming. In terms of conflicts of interest, I just want to disclose first that I am a site principal investigator for 2 industry-funded trials of Fragile X, Shionogi, previously Tetra, and Harmony Biosciences. I will talk a little bit about these trials in the context of why we're doing them, but will not be sharing anything that is not allowed to be shared. And then Susan and I both have consulting contracts to provide education about Fragile X to the Shionogi group as well. Here are the learning objectives: explaining the genetic basis of Fragile X syndrome, identifying common clinical features of Fragile X across the different stages, describing the relationship between Fragile X and autism, discussing current treatment options, and then recognizing the importance of family education and counseling in management and support. So I'd like to start first just with a case study. This is actually a real case of a patient that we work with who's now a very productive adult. But this was his diagnosis. And so I thought we would start just talking about the course to his diagnosis. So at birth, he was born with something called strabismus, or his mom noticed that he was a healthy baby, except for, had severely crossed eyes that weren't aligning correctly. At 3 months of age, he started having really frequent ear infections, and these continued. And then at 4 months, she became more concerned that he wasn't tracking as well as he should have, and was being evaluated further by ophthalmology. By 6 months of age, ophthalmology had started with patching and not necessarily glasses at that age, but patching the different eyes to see if it could help with the alignment. And he was also diagnosed with an inguinal hernia. Um, when tracking his development at 8 months, she started becoming concerned that he still was not sitting up independently. He wasn't crawling and meeting milestones as she was expecting and as she had seen in her other children. He had a PT evaluation when he was 9 months of old, 9 months of age, and diagnosed with hypotonia or low muscle tone, and started with physical therapy at that time. At 10 months, he was identified to have delays again in his speech as well as his motor skills. He got ear tubes at 12 months of age. She felt like he was very irritable, had a lot of crying. At 18 months, he was seen for a multidisciplinary evaluation, not necessarily screening, but really big evaluation. And then at 20 months, started in speech and occupational therapy. He did start walking at 20 months, at that time a lot on his toes, but he was walking. They switched pediatricians as well at that time. And the new pediatrician said, well, why come, we need to do genetic testing, and tested for Fragile X syndrome. And then at 22 months of age, she got a call from the pediatrician after the genetic testing came back and said, well, he's positive for something called Fragile X. And she had never heard of it, like many have not. And she said, fragile what? And so at this point, I'm gonna mute myself and have Susan take over in terms of the next steps of the presentation.
Thank you, Dr. Tartaglia. So to start off with, the prevalence of Fragile X is relatively common compared to other genetic disorders, affecting approximately 1 in 4,000 to 7,000 males. And it's caused by a gene that's on the X chromosome, so the prevalence is less commonly diagnosed in females, having 2 X chromosomes typically, with about a prevalence of about 1 in 8,000 to 11,000 females. And that's due to the second X chromosome causing the phenotype to be much more variable. The premutation, which we'll talk about more throughout the duration of this presentation, is more common. So these are carriers of the mutation before it becomes Fragile X syndrome, and that can be as common as about 1 in 200 in females and 1 in 400 males. So carrying this condition can be relatively common. It's the most common cause of an inherited intellectual disability and the most common single gene genetic disorder causing autism. And it affects all races and ethnicities. So when we're talking about testing for Fragile X and making a diagnosis, we're going to kind of back up a little bit in biology. So inside of a single cell in the body, we have the nucleus that contains the chromosomes, and the chromosomes are the structures that carry all of our genes. And so when we're talking about Fragile X, we're talking about a specific gene. So if we look at the X chromosome, this specific gene is at the bottom of the what we call the long arm or the Q arm of the X chromosome. And we have lots of chromosomes that we have in each one of our cells. So typically we have 46 total chromosomes that come in pairs. And so they're numbered 1 through 22. And when we're talking about Fragile X, we're talking about the X chromosome. So that's our 23rd pair, whereas females will have 2 X chromosomes or 2 copies of this gene. And males have just a single X chromosome, and the other chromosome is a Y. And so they only have 1 copy of the gene. Next slide. Dr. T. Sorry, Dr. T is directing the slides, so I'm trying to get him to advance.
I'm trying. Hold on. I don't know what's going on. Huh. It won't move.
Strange.
Yes. Okay. Well, I'm going to stop sharing and reshare.
Perfect.
Share. Well, I'm going to actually, hold on. Escape. Okay. Now I'm going to share again. This. Share. Share. There.
Okay, here we go. So the gene that is associated with Fragile X syndrome is called FMR1, standing for Fragile X messenger ribonucleic protein 1. It's just a big, fancy long term. And so the gene is on the end of the X chromosome. And before we could actually do DNA testing, they would stain the chromosomes. And at the end of the X chromosome, they would see this area that was considered fragile. It looked like kind of a thread that had the tip of the X chromosome hanging off. And so that's where the term fragile came from as far as Fragile X. And then as we learned more about decoding DNA and being able to do genetic testing and reading through the DNA, then we learned more about the FMR1 gene. And in this gene is a promoter region that's labeled in green. And this is where we're doing the actual testing for Fragile X. So within this promoter region, we naturally, we all have this gene and we all have this area, but what we're doing when we're testing for Fragile X is counting a trinucleotide repeat that's CGG. And so the DNA alphabet containing 4 letters, these are just 2 of the letters that are naturally found in a repeat in this area of the gene. And so we're counting how many CGG repeats are in this area of the gene when we're testing for Fragile X. And hopefully the next slide works again. We're having technical difficulties. Okay, so the testing for Fragile X is counting the CGG repeats that we see. Commonly in the general population, we'll see somewhere between 6 to 44 repeats. So we all have, on the X chromosome, we all have this gene, we're just counting how many we carry. When an individual is considered a carrier or a premutation carrier of the condition, they have an expanded number of repeats, somewhere between 55 and 200. That's diagnostic for a premutation. And then Fragile X syndrome happens from the full mutation. And this is when the CGG repeats are more than 200. And so when the test identifies more than 200 repeats, then it's considered a full mutation and diagnostic of Fragile X syndrome. So these classifications, we're going to talk a little bit more, but for the sake of this case and really presenting about what we see in kids affected with Fragile X syndrome, I'm going to have you advance a slide. We're going to focus on the full mutation. Oops. So the full mutation, in the DNA, we have more than 200 CGG repeats, like we talked about. And what happens with that is the gene gets methylated. And that's a process in which the body turns off the expression of that gene. And so without the gene being expressed, we're not able to make either the message mRNA nor the protein called FMRP. And it's the absence of the protein that causes Fragile X syndrome. And so with that, I'll turn it back over to Dr. T, and she'll talk to you more about the management and the various features that we see in Fragile X syndrome.
Okay, I am having a really hard time with these slides, and I'm not sure why. I'm going to start with a video that is, I think, a nice demonstration from some Fragile X families. And let me open this and people can tell me, can you see and hear this? Susan, can you nod?
I don't see anything yet, Dr. T.
No. Okay. Well, let me see what's going on here then. Do you still see the screen with the video?
Nope, not yet.
Do you see the screen with the slides?
I just see you.
Oh, oh my goodness. What
I
a baby mess. We even practiced all of this.
No. And I don't know if Christine, since she has a copy, or Dina has a copy, if maybe they can take over.
Maybe let me try this one here. I'll go just to the specific window. Can you see that?
Yes.
Okay. Now hopefully you can hear it when I play it.
The diagnosis, and there is no time to pull the covers over your head. And I clearly know my life is going to be very different than when I anticipated it to be.
I never heard of Fragile X until my sister, she has 3 boys, and 2 of them have Fragile X syndrome. If my sister's a carrier, I could be a carrier.
We know now that about 1/3 of all children with Fragile X syndrome will also have autism.
I know in Mexico a lot of kids are just kind of hidden away. It's not very often that you see a family who has a disabled child out in public.
Garrett at this stage, I don't think knows that he's any different. But I don't think that will last. I think once he gets into school and gets a certain age and starts to develop more cognitively, he'll know that he's terribly different. And that will break my heart.
I wanted him to be normal. And if I have any regrets, is that I did not let myself love him at that moment. Just say, I love you just the way you are. And I hope he forgives me for ever thinking I wanted him to be different.
Okay. So I love that video because I think it shows a lot of the, Fragile X clinical features and mannerisms, but also shows many of the, all the love and smiles and really endearing qualities of Fragile X as well. So now I'm going to try this video again, get back to our slides right here. I'm going to not do that. I'm going to share here. And then I'm going to do this, and I'm going to see some nods from Susan that you can see everything. And hopefully we can advance it. Oh, look at that. Okay, so we're going to start by talking a little bit about physical and medical features of Fragile X. When we see these following features, then, these are kind of some of the hallmark features of Fragile X. Not everybody shows all of these features. And so, but they're the things that the doctors and medical providers, geneticists will look for that gives us hints that there may be a diagnosis of Fragile X syndrome. So some of the things we see are macrocephaly, or large head circumference, a long face, a long or prominent ears with cupping. So you can see on this little guy, he's got prominent ears, and cupping means it's a smoothness of the pinna of the ear, or the external part of the ear, that doesn't have quite as many ridges in it. We can see a high arched palate. I'll show you some pictures of that in the next few slides. Really soft, smooth skin. They have hyper flexible joints, double jointed thumbs, flat feet, pronation at the ankles, hypotonia or low muscle tone, and then macroorchidism in males, which is large testicles that doesn't develop until after puberty. So here's a few other pictures. These are 2 siblings with Fragile X being silly. And you can see, a little bit of prominence of the ears here, but not as significant as in the other one. And this guy has long ears, but not necessarily as prominent. This is an example of a high arch palate that you can see up there. And so that's one of the other features we can see in Fragile X. And another cutie with, who has a little bit of macrocephaly and some prominence of the ears as well. Here is a picture of a mom and daughter who both have Fragile X syndrome. And you can see some of the strabismus or the malalignment of the eyes that we saw in the first case study. And so this was a feature in both of these women and young child. Here was us testing for all these hyperflexible joints, and many times they'll be able to show you all the ways they can bend their joints. And then a picture of flat feet with some of the ankle pronation that we can see as well. When we look at actual medical problems that we see in Fragile X, this comes from a paper that was a big study funded through CDC, and really where we looked at a national sample of children. And in Fragile X syndrome, recurrent otitis media or recurrent ear infections occur in about 52% of all patients. The lazy eye / strabismus or refractive errors are also present, not as commonly, but in about 16%. About 10% have seizures. About 50 to 80% have the flat feet. About 10% develop scoliosis. And then there can be a lot of GI or feeding disorders as well. Feeding difficulties in infancy are common in up to 25%. GI problems such as constipation, loose stools, and reflux also occur in about a third of patients. And then other kind of feeding difficulties, overstuffing, picky eating, which we don't have great data on, but that definitely can occur. And then sleep disorders are very common difficulties, difficulty falling asleep, staying asleep. We know there's actually dysregulation of the melatonin pathway in Fragile X when you're missing the FMRP protein. And so sleep can be really tough. And then sleep apnea can also occur almost up to a third of patients. And then there's very commonly delays in toilet training. So toileting needs are commonly an area that need to be addressed in clinic. When we talk about developmental and behavioral features, there's always a distinction between talking about males with Fragile X who have only that one X chromosome, so their X is very affected, compared to females who have two X chromosomes, and there's a lot more variability in how females with Fragile X present, and we'll talk a little bit more about those as well. But when we look at early milestones in males, motor and speech delays are very common. The mean age at first steps is 17.8 months based on a study that was done. So usually around 18 months. And 45% end up being delayed, which is defined as, over 18 months at first independent walking. Later challenges occur with fine and gross motor coordination and motor planning difficulties. And then in terms of speech and language, the mean age of first words is around 2 to 2.5 years of age. Over 65% of individuals males with Fragile X have delayed speech. Like I said before, about 12% are nonverbal throughout the course of their lifespan or have very few words. And then the mean age of two-word phrases, which in the typical population occurs at around 2 years of age, really doesn't happen until around 3.5 years of age in Fragile X syndrome. Later speech often includes atypical speech development with rote phrases or little memorized phrases, stereotyped and repetitive speech, and sometimes atypical intonation of speech, speaking really quickly, or with some echolalia, echoing what the phrases and terms that they hear. In females, like I said, there's a lot more variability, and this has to do with, again, the second X chromosome does make FMRP. And so depending on how much it makes and where it's expressed in the brain versus other parts of the body, there can be differences in terms of how females present. But around 35% of females with the full mutation present with delayed milestones. These rates of delays are lower than males. And so on average, this also makes the delays be diagnosed at a later age compared to females. So they usually are identified to have delays around 2 years of age. Instead of earlier as we see in the males. This is a picture from a Fragile X conference where there was a whole program for females with the Fragile X mutation. And we will talk a little bit more about outcomes, but there's a nice range of outcomes with many and most, having really successful adult outcomes with varying degrees to no disability later. So in cognitive functioning, when we do cognitive assessment in males with Fragile X, almost 100% of males meet criteria for intellectual developmental disorder, or IDD. On average, IQ testing falls between 40 to 55. On the standardized assessments, approximately 10% are nonverbal. Just because they're nonverbal doesn't mean they don't understand almost everything you're saying some of the times. And so we see a big significant difference between expressive and receptive language skills. While IQ scores tend to be low, there's definitely a very broad range of adaptive functioning and adaptive outcomes in the general population, or in the Fragile X population, that's much broader than the IQ. And so there's a lot of life skills abilities that can range from, still needing significant supports to many of our males living independently as adults with continued disability supports, but being able to work and have very successful, meaningful lives. In females, like I said, it's broader. In general, we divide them into 3 big categories. About a third do meet criteria for IDD. About a third still have challenges in terms of having difficulties such as learning disabilities, anxiety disorders, ADHD, but they don't meet criteria for IDD. And then the other third can have average IQ or above and not really have very many cognitive impairments at all. So when we talk about developmental and behavioral features in Fragile X, there are a lot of challenges that can occur, and this is the cognitive problems. If the developmental delays are the reasons the kids show up for diagnosis and for clinic early on, but the reasons we follow them as they go and become older is because there can be many developmental and behavioral concerns as well. So we can see a lot of sensory sensitivities. We see high rates of anxiety, both generalized anxiety, social anxiety, and some selective mutism. That's very common, especially in the females. We can see a lot of compulsive rituals, routines, kind of OCD types of behaviors. We can see repetitive motor behaviors such as hand flapping or hand biting and other self-injurious behaviors when they get frustrated. Some rocking behaviors. Gaze and eye contact avoidance is very common in Fragile X syndrome, where there's a discomfort in making and maintaining eye contact. Stereotyped and repetitive speech, like we talked about. ADHD, attention deficits, and impulsivity, hyperactivity are very common concerns. And then also sometimes challenges with mood instability, tantrums, and aggression. So there's a lot of different challenges. Not everybody has all of these, but these are the symptoms parents come in with that they have concerns about that are causing challenges for their kids. Many of these fall into different, actual neurodevelopmental diagnoses, right? There were a lot of symptoms we talked about that parents report ADHD, and we do see diagnoses of meeting criteria for ADHD in about 85% of males and almost 70% of females. Anxiety is also very common, 70% to 56% in females. Autism spectrum disorder is a common co-occurring diagnosis in Fragile X, and can be present, depending on the study, up to 50%, even 70% in some studies. And autistic behaviors are almost universal in males with Fragile X, whether or not they meet full criteria. And then females can occur in about 20%. Self-injury can also be an area of challenge that needs to be addressed, as well as aggressive outbursts. And again, you can see those differences between males being more impacted, more likely to be impacted than females. But, you know, on the other side of it, when females are affected, they're just as affected. So sometimes females tend to be, the treatments and support tend to be minimized because, you know, oh, females aren't as bad. But in general, if they're having challenges, then, you know, we want to make sure that those females, even though they might be a minority, are still getting the supports that they need. So we've talked about the clinical features. Now I want to spend a little bit of time just moving on to talk about diagnosis of Fragile X and then treatments for Fragile X. So in terms of diagnosis, there was a great study done by Dr. Don Bailey et al. That was published, you know, a while ago, but still is pretty much true in terms of average age of diagnosis and talking about diagnostic rates in the family. So the average age of diagnosis when you don't know there might be Fragile X in the family for males is 3 to 3.5 years of age, and for females is 3.5 to 4 years of age. But there's also a much broader range of when females are diagnosed because of this milder presentation. The presenting symptoms are most commonly developmental delays. Second most common is related to autism or autism features. Parental concerns, while the diagnostic age might be 3 to 4 years of age, parents became concerned on average at a year of age in males, sometimes from birth, like the case we talked about, and on average at 16 months of age in females. So you can see this gap between when parents started to become concerned and then when diagnostic you know, testing was actually done. And that gap, oftentimes parents will describe, you know, they were reassured, boys just developed slower, you know, boys, you know, his older sister's talking for him, and all of these things where parents kind of had a hunch that there was something going on much earlier. In families who didn't know, again, who did not know about Fragile X in their family, 25% of families with a male child had already had a second child with a full mutation before the first child was diagnosed. So, you know, if you have one child who's 3 years old, many times you've had another child or are pregnant, or even a couple times after that. And so we have many families where when the older child is diagnosed, we end up identifying multiple cases in the family. And so we have many siblings in our clinic. And then in 40% of families who had a female child, with Fragile X had a second child with the full mutation. Because again, females were tended to be diagnosed later, so you're more likely to have other kids after that. So, you know, when children present with developmental delays, to medical providers in all my teaching, I always say, you know, people say, well, what's the rush in doing genetic testing? Well, some of the rush is that when there's a young child with a potential genetic condition in the family, then that mom is of childbearing age, where she could have other kids, and there's a whole generation of people in that family who are of childbearing age. And so, you know, there is some urgency so families can know about the diagnosis and then be able to make appropriate care decisions moving forward. So when we talk about like what is the actual indication for genetic testing, when should Fragile X genetic testing be ordered, and what tests do I order? So on the left side of the screen, you'll see the current recommendations through the American Academy of Pediatrics and the American College of Medical Genetics, that these are the following people. All physicians should order Fragile X DNA testing on these people: males, children and adults with IDD, males, children and adults with autism, males with developmental delays, global developmental delay, or two domains of delays, and then females who have developmental delays, IDD, or autism, and then also have a family history of Fragile X related disorders. And so basically it doesn't have for formal recommendations for female testing includes that family history of Fragile X related disorders, but really we think it's much broader than that, and really females with developmental delays, IDD, and autism should be tested for Fragile X syndrome. The yellow boxes here, there's a lot of different testing methods you can do to look at the FMR1 gene. The big one that is the first line of screening and the one that everybody should be doing, or first line of testing, is called Fragile X DNA testing. And this can be done either on blood or by cheek swab or prenatally through carrier screening. And this gives us a diagnostic Fragile X result. That's really important. There are other tests you can do that will pick up some very rare cases of Fragile X, FISH testing, microarray, exome sequencing, but current recommendations for sequencing intellectual disabilities do not pick up Fragile X. And so if there's intellectual disability, the current recommendations are you should do sequencing and Fragile X DNA testing. Hopefully the sequencing tests evolve to be able to identify Fragile X, but they don't currently. And so Fragile X DNA testing is the most important part. It'll come up with a PCR test that tells you if there's a CGG expansion, and then additional testing such as Southern blot or genotyping by PCR will, be follow-up to that. But this Fragile X DNA test is a place to start, and then the additional testing telling us about methylation and all sorts of other things Susan will talk with you about, will be reflex to that. When we talk about management, okay, so we've, ordered a Fragile X DNA test. It's come back positive for Fragile X. We know that there's a new child with Fragile X. Then what is the next step in terms of management? So anytime there's a new diagnosis, really important first step is genetic counseling and all of the supports that come along with further evaluation related to genetics in the family, and then social work and community supports and those types of programs and opportunities that will help with supporting the family. So we always, involve genetic counseling, and Susan is going to talk a lot about what that involves and how it is so important in the family. We involve our social work team to help be connected with intervention services, with community and disability services, and to help support family mental health coping with the new diagnosis. We also make referrals as needed for early intervention, speech, OT, PT as needed, child psychology for different evaluations related to cognitive and adaptive functioning to help in the school setting or occupational setting in older patients, comorbidities, looking for and identifying those that meet criteria for ADHD and autism, and really looking at all of those co-occurring conditions, and then recommending the types of other behavioral therapies that may be helpful. We also make sure that the physician is screening for all of those Fragile X associated medical conditions that we went through at the beginning. The ear infections, the strabismus and vision, the orthopedic differences. And so all of the sleep problems, all of those need to be screened for as well. And then we talk about medication treatments, and I'll tell you a little bit more about some of the options in terms of medications. Facilitating medical care is another big part of how we can help support families. Many times, even before the diagnosis of Fragile X, families are aware that coming to medical appointments can be really challenging. But for any providers watching this presentation, it's really important to think about, how to support the Fragile X family in a pediatric or adult care environment. Medical appointments can be very challenging, related to anxiety, related to sensory sensitivities, relating to challenges with waiting in the waiting room, which can then distress everybody and make the whole appointment kind of fall apart if you can't even have a successful successful start of the appointment because they've been waiting too long. It's also really important to recognize that women with the pre-mutation or full mutation are at higher risk for anxiety and anxiety disorders. And so there's an extra component of the moms often being more anxious about the medical care and anxious about the behaviors of their children in the medical setting that can also really make the appointment challenging. So we do a lot of accommodations in terms of asking parents the best approach to scheduling, first thing in the morning or right at the end of the day, which might be best when, they're not going to have to wait. What's the best approach to the exam? They can't stand their ears being examined. That's certainly not the first thing you start with. Really just being accommodating to what they need. I will tell you there's many a Fragile X appointment I've actually done in the car because the parents can't get them into the hospital and into the clinic because of anxiety related to a new setting or sensory sensitivities. And so, we just kind of truck out to the car or the parking lot. We use a lot of the exam techniques that we use for children with autism and other disabilities, picture schedules, video modeling. I do a lot of, okay, 1, 2, 3 on this side and I'll be all done. I tell them what I'm going to do. Many will do what we just call practice visits. There's a couple of patients who just come and sit in the waiting room just for the sake of being used to coming into the clinic, and they don't even have an appointment. They just sit there for 10 or 15 minutes and then they go on with their day, and that helps with the appointment when it does come time to come in. And then telehealth has been amazing in terms of our ability to do home care by telehealth. And so, that can either shorten the in-person visit, so all we have to do is the exam, so we don't have to do a lot of history taking, or we do a lot of medication management just by telehealth without needing in-person visits. So here are many of the different medical problems we talked about. And then here are the different management approaches for providers. And so we've already spoken through many of these, but the idea is that, with a new diagnosis and with follow-up evaluations, you're evaluating for typical pediatric care, and then adding on extra screening and referrals for those medical problems that are more common in Fragile X syndrome, like recurrent otitis media, the strabismus. We ask about seizures, and then you can see referrals and other evaluations as needed for all of those different pieces. Psychopharmacology in Fragile X, or medications for behaviors and other types of challenges in Fragile X, are a big part of what I do in Fragile X clinic. This can also be done by primary care providers, or at least started by primary care providers, but most clinics will also be very helpful in terms of providing guidance. So medications for behavioral problems such as ADHD, medications for sleep difficulties, medications for seizures, obviously, if they need them. And then we have medications that are currently being researched in clinical trials, and we'll talk a little bit about those. Basically, before we talk about medication management, I always feel like, we feel like medications are often a part of the treatment pie in Fragile X, and the piece of that pie and how big it is can be very different depending on the different individual. But, the treatment includes all the other behavioral therapies, educational supports, community therapies, parent strategies, OT, PT, speech. So every individual has different programming and therapies that are needed depending on what their needs are. And for some individuals, medications aren't needed. And for other individuals, medications are really needed to help them. And the idea is that we're trying to address behavioral challenges that are causing impairment. And so, it's not just that, we can't sit still, and so we're going to start medication. But if his inability to sit still or those attention problems and hyperactivity are making it so he can't participate in speech therapy, he can't be successful in a social setting, he can't be successful in a school setting, well, then that's causing impairment and limiting his opportunities in the classrooms, in the world, limiting his opportunities to benefit from therapies. And so when behaviors are causing those types of impairments, causing safety concerns, that that is when we would start to think about medication management. The targets are to improve functioning, improve whatever those target behaviors are. We also want to obviously prevent any safety concerns, dangerous behaviors. When we start medications, we start to target the most important or the most impactful behavior. We have many children who have, attention difficulties and anxiety and self-injury and aggression. We would not, we may end up treating all of those in different ways with more than one medication, but we don't just start, giving them all at the same time. So we pick the one that's most important, causing the most impact, and start with managing that one, and then see how other things look after, hopefully that one is improved. In general, we would start medications at low doses in individuals with disabilities and, raise the dose very gradually to make sure we're not causing side effects or more challenges. This is a study that was also done by Dr. Bailey and published from a national survey of caregivers about how commonly medications were used in their children and adults, and what they were used for. So you can see here in males, over 30% were on, like you just look at that first bar, the most common medication category that was being targeted was for anxiety, and over 30% of males were on one or more, over 30% were on one medication for anxiety, and then some were on two or more, and then also for females up to 20%. So again, it gives you these figures, I think, give you a good idea of many individuals were on medications for all these different areas. Not, there's a proportion of the population that benefits, and some may need even more. This actually looked at, what the perceived efficacy. Did parents actually think medications were helpful? And when they did try them, and then when they were helpful, were they a lot helpful, which are the green bars? Were they somewhat helpful, which are the red bars? Or were they really not that helpful, which are the blue, the blue portion of the bars? And so you can see here, there definitely were, about a third of individuals who said medications were a lot effective. I will say sometimes even somewhat effective is definitely better, and, helpful to help with daily functioning. And then, but sometimes, they weren't effective. And so in those situations is when, a lot of behavioral supports and other types of therapies are really important to target those behaviors and symptoms as well. These are the different classes of medications that we use. And so, stimulants and non-stimulants, alpha agonists, SSRIs, antidepressants or anti-epileptics, atypical antipsychotics. So this is a little bit above the idea of what we're going to do in this talk. But the different physicians will work with, families to work on identifying the target symptom and then the best medications to start with. The green bar at the bottom is what we call is a new area in Fragile X. Well, not new, maybe the past 15 or 20 years, but we call targeted treatments in Fragile X. And this is a really exciting area where there's a lot of research going on. I'm not going to spend a ton of time talking about this, but targeted treatments are the idea that we know that FMRP is missing, that protein. And when you look at a synapse, there are a lot of different pathways and receptors and neurotransmitters that are affected when you are missing the Fragile X protein. And so all of those different molecules and receptors are potential targets for medications that may treat Fragile X even more, specifically compared to treating just general anxiety or general ADHD. And so there have been many trials that are targeting different aspects of these pathways, looking for, medications that may be more helpful in Fragile X syndrome, and those are called targeted treatments. Some of these treatments are FDA approved already for other indications, but we know from studies that they also target the Fragile X pathway. So sometimes you'll see individuals with with Fragile X on metformin for treatment of irritability and aggression, and that's because it also works on this AKT or mTOR pathways. Sertraline is another one, also called Zoloft, that treats BDNF, boosts that up, which is a neurotrophic factor, a nerve growth factor that's been shown to help with some aspects of speech and motor development, especially in kids who have co-occurring Fragile X and autism. CBD or cannabidiol works on the endocannabinoid pathway, which is specifically dysregulated when you're missing the FMRP pathway. So it's targeting that endocannabinoid difference. And then also other ones like minocycline and lithium and others. There are 2 currently industry-sponsored clinical trials in phase 3 going on right now. One is called the Experience trial, and it's a medication that's a phosphodiesterase inhibitor, where we're looking at improving cognitive skills or actual problem-solving skills using the NIH toolbox to measure these changes in skills over time. And then there's another trial that's called the Reconnect FX trial, looking at a transdermal gel called Zygel, and the improvements to social avoidance symptoms in Fragile X syndrome. So these are really exciting trials to be involved in, because the idea is if we have something that really targets the underlying pathway in Fragile X, then hopefully we can use it in younger and younger kids to lead to, really improved outcomes and decreased amount of disability caused by the behavioral symptoms. Okay, so now I'm going to move it on to Susan to talk about genetic counseling.
Okay, I'm trying to undo my video. I might need some assistance with this. Hopefully you can hear me. Okay, here we go. Okay, so we've talked a lot about the management and understanding the diagnosis from a physical and psychological and behavioral perspective. But when we talk about genetic counseling and Fragile X, there's a lot more to the conversation. And so counseling sessions also commonly include significant discussions around the inheritance pattern, because it is an inherited condition, and the risk to both the family and siblings, as well as extended relatives. Discussions around family planning options, and so making informed decisions, understanding the inheritance and the risks. And then also cascade testing. So cascade testing is a term that applies to once the first member of the family is identified to have a genetic condition that's inheritable, then testing other family members who are at risk of also having that inherited genetic change. We talk a lot about in counseling around the FMR1 pre-mutation associated conditions, which I'll touch on briefly, as well as a lot of the psychosocial issues and supports. And we'll have Dr. T advance the slides, hopefully. Okay, so the pre-mutation we didn't talk about previously, so I'm going to talk about it now. So we all have this gene, and when we're measuring the gene, we're counting the CGG repeats in testing. When CGG repeats are between 55 and 200, they are diagnostic of a pre-mutation. And so this is not Fragile X syndrome, but this is an expansion in the gene that's at risk of getting larger in the next generation, especially when it's from mother to child. And what happens when an individual has a pre-mutation is that the gene is transcribed in excess, making a lot of what we call messenger RNA, or this message in the cell. And we can see symptoms in pre-mutation carriers, like the mother of a boy with Fragile X syndrome being a pre-mutation carrier. We can see a lot of symptoms that can be associated with this excess mRNA, and a couple different specific conditions called primary ovarian insufficiency or early menopause, as well as a condition associated with tremors and ataxia, which I'll talk about in a minute. So Fragile X, the inheritance pattern is X-linked. We already talked about it, it's on the X chromosome. And so if we are identifying individuals as carriers at risk for having it inherited in the next generation, when we see women, we know that having two X chromosomes, they have two copies of this gene. And so one of the two can have this expansion and a premutation. And when it's passed on from mother to child, it can get larger. When we see males who have a premutation or an expansion in the gene, then we know that they have the single X chromosome. So when a mother is a premutation carrier, it's a gene that expands in the next generation only when it goes from mother to child. And so we know that just like flipping a coin, there's a 50-50 chance with each pregnancy of which X chromosome she's going to pass on to the next generation. So if she passes on the expansion to a daughter, there's a 50% chance for her daughters as well as a son, a 50% chance, right? Because she's giving one or the other X chromosome. If it is inherited from a father, being the premutation carrier, when a father has a child, if the child is a daughter, he gives his X chromosome. So all of his daughters get his X chromosome, but it tends to be stable in transmission going from father to child. It does not typically expand. So what we most commonly see is that fathers with the premutation have all of their daughters also be premutation carriers and none of their sons. So it's never transmitted from father to son, and that's because fathers give their Y chromosome to their son, and the sons get their X chromosome from their mother. When we talk about Fragile X, we're talking about a phenomenon called genetic anticipation as far as the way it's inherited. So when it's typically passed on in this depiction from at the top of the screen, the 82 refers to a male, like a grandfather, and he gives his X chromosome to his daughter. In this case, it got slightly larger, but did not jump as a huge expansion. And so it went from 82 as a premutation to his daughter as 89. And then when she goes on to have children, knowing that it can expand when it goes from mother to child, it jumped from 89 all the way above 200. And so it was a premutation mother who passed on that X chromosome to her son, and then the son had the expansion over 200, diagnostic of Fragile X syndrome. And so the question that commonly comes up in genetic counseling is, what is the likelihood of having a child or having a grandchild with Fragile X syndrome? And so that's dependent on kind of two factors. One is the number of CGG repeats that a woman commonly starts with, as well as if there is a presence of any AGG interruptions, which I'll explain about as well. So generally, when we're just talking about CGG repeats, we have some statistics about the likelihood of a mom's repeat based on CGG count to expand to the full mutation in the next generation. And this is just generalized population risks based on studies that were led by Dr. Nolan back in 2015. But we now also know information about the second factor being AGG interruptions or anchors. And so AGG interruptions are present in normal CGG repeats. There can be 0 AGG interruptions, and this is where the A standing for a different nucleotide is replacing the C in the repeat, right? This is a natural occurring difference that can happen in the gene. And so we can see anywhere from 0 to 3 AGG interruptions, where instead of having the C, it'll have the A. It typically occurs around every 9 to 10 CGG repeats. And what's really important about AGG interruptions is that when they are present, they have a stabilizing impact on the transmission of the gene. And so it's more stable and therefore less likely to have a big jump in expansion when we have lots of AGG interruptions or anchors. And the study that really demonstrated this impact was looking at the personalized risk, not just based on the CGG count that a woman is starting with, but then looking at the presence of AGG interruptions. And so this is much more of a personalized test. It tends to be a reflex test after a woman has had CGG testing. And that's because the AGG anchors or interruptions have the biggest impact when a woman starts with between 60 and 90 CGG repeats. And so that's really where the bottom, the x-axis of this graph really highlights, is that 60 to 90. And what you can see in the picture is that when there are 0 AGG interruptions, as depicted by the light blue dotted line, there is a higher risk in the kind of the middle of the risk. We're talking about around 78 CGG repeats to start. But if a woman has no AGG interruptions present, then there can be an 84% risk for her to have an expansion of that gene in the next generation to a full mutation. So again, to say that if a woman starts with 78 CGG repeats, AGG testing shows no interruptions, her personalized risk for having a child in the next generation or having a child with a full mutation would be 84%. If that same woman, test results showed that she had 2 AGG interruptions, as depicted by the green dotted line, this has a much more stabilizing effect, and therefore that risk goes all the way down to 18% is a personalized risk. So the take home is that AGG testing is very informative for women of childbearing age who are interested in knowing their personalized risk of having a child with Fragile X when they have 60 to 90 CGG repeats, because this testing can be very informative for personalized risk. And when we're talking with families, especially when we identify, for example, the mother of a boy with Fragile X syndrome is identified as having a premutation, then we spend a lot of time, and I'm not going to spend too much time because this could be a talk in and of itself for an hour, but we spend time talking about risks associated with conditions in the premutation due to that excess mRNA or that excess message. So it's not just about reproductive risks. The 3 main conditions that we talk about associated with the premutation is Fragile X tremor ataxia syndrome. And so that's FXTAS or FXTAS is the term that's commonly used. And this is a progressive neurodegenerative disorder with an onset typically over 50 years of age. Males tend to have a age-related risk, and so as they get older, if they carry the premutation, their risk of developing FXTAS over 50 increases, whereas women typically have around a 16% lifetime risk. It's a condition that's associated with symptoms of motor symptoms with tremors, ataxia, Parkinson-like symptoms, balance problems. We can see cognitive deficits, executive functioning deficits, memory problems, and dementia, and mood disorders we commonly see. And so this was actually identified by a developmental pediatrician, Dr. Hagerman, even though it's a condition affecting the elderly, because she kept hearing about grandparents and grandfathers that had similar symptoms. And so that's really what started the investigation into this condition. But we hear a lot of struggles from families who are navigating this around mood disorders too, with increasing irritability and anxiety and depression in that older generation. And it's diagnosed typically by a neurologist that's familiar with FXTAS and specific MRI findings of the brain on imaging. The other condition that one other condition that we can see more commonly is called Fragile X primary ovarian insufficiency, or FAX-POI. And so this is, by definition, when we see early menopause or menopause before the age of 40. And what we see is that the highest risk is actually, there's a kind of a curved linear relationship, like a U, where the highest risk of having early menopause is for our carrier women, because this only affects women, is ovarian insufficiency, around 85 CGG repeats. So kind of in the middle of that 55 to 200, that the risk for menopause is the lowest age. And then we know that you can still get pregnant, even when you're experiencing FAX-POI. About 15% of women with FAX-POI can still get pregnant. And then the last kind of described condition is Fragile X-associated neuropsychiatric disorders, or FACS-and. So this is a compilation of symptoms associated with psychiatric and neurodevelopmental symptoms, commonly characterized by anxiety, especially social anxiety, and depression. We can see obsessive compulsive disorder, mood instability, ADHD, autism-like traits, sensory sensitivities and problems, and executive functioning deficits. And then lastly, there are some symptoms that we talk about with our families in regard to other associated premutation conditions, autoimmune disorders, fibromyalgia, neuropathy, migraines. We often hear about speech delays or developmental delays, some learning problems, especially premutation carrier women will often endorse math difficulties, and then hypertension as well. So when we're performing genetic counseling or providing counseling to families, a big component is taking a very detailed targeted family history. And that's because we know that once an individual, like the bottom left of the screen, this is the little boy that was diagnosed, depicted with the arrow, diagnosed with Fragile X syndrome. So once the first individual in a family is identified, on average, we see somewhere between 5 and 10 additional family members identified afterwards, right? So this really reflects the cascade testing. So understanding X-linked inheritance and knowing, the risks and identifying the risks to associated family members, knowing that it can get bigger when it goes from mother to child, it never passes from father to son, and just understanding the pattern, really working with the family and trying to identify additional family members that should be tested. It's very important to understand, though, that we don't ever assume the status for a relative without genetic testing. That we really have to do testing to understand whether or not they are a carrier of a premutation, or if a woman has a full mutation, for example. Another component of genetic counseling is often disclosure, right? So once an inherited condition in any family is identified, talking to relatives about their potential risk and the importance of getting genetic counseling and possibly testing for themselves is a natural component of this. So families will often ask about, getting testing. Wait a sec, do I need to test myself? Is there anyone else in our immediate family that may have this? What about my younger child, like Dr. Tartaglia was referring to, that often there's younger siblings that may have it, and then understanding that it can affect the older generation as well as aunts and uncles and cousins, understanding that grandparents and cousins and aunts and uncles may or may not be interested. And so until you start talking about it and testing, you really don't know exactly who in the family is at risk, because you can't clarify the status and which side of the family it may be coming from, unless it's very obvious, considering kind of obligate carriers, knowing that boys get their X chromosome from their mom. And family responses to this is often very mixed, right? So you may reach out to a loved one and talking to them about their risk for an inherited condition, and some people are very, eager to get everyone tested, and other families just don't want to know about it, and they really, they'll present like, I don't care. And so often helping support families in navigating some of those responses and trying to identify who in the family has the greatest risk to make sure that we're being targeted if we run into some roadblocks along the way. And so it's really important that individuals and families get referred to genetic counselors. There's a lot of psychosocial impacts with a new diagnosis, especially it's often very blindsiding. If a family has a 3-year-old that is experiencing delays, much like the initial case, the delays are not necessarily surprising, but identifying a condition that is associated with inherited risks to other children, individual risks to the parents as far as early menopause or FACS-TAS and the tremor ataxia risks, knowing that it's a lifelong condition and the financial impacts, that grief is a really common encounter with a new diagnosis, and it's an emotional journey. So it's really important to help families identify both family and individual supports as needed, recognizing that often there's emotions of guilt, knowing that's an inherited condition that families were not aware of, and letting other families know and how to disclose and discuss the diagnosis, can be very emotional as well. And so trying to help support families throughout their journey is really a key aspect of genetic counseling as well. There's a wide variety of resources that we've included in our slide deck to make sure that we're sharing them with you as well. And so I'm not going to read through these. The National Fragile X Foundation is the most likely kind of go-to resource for genetic counselors to share with families. They have a lot of very accessible information, previously recorded talks, access to published journal articles, videos that families can watch. It's a wonderful organization that has a lot of family oriented information. They also have affiliated with the Fragile X Treatment and Research Consortium, or the FXCRC, and some documents that are consensus documents. So these are not peer-reviewed articles, but a lot of accessible, downloadable information through their website. And then the National Fragile X Foundation has Fragile X clinics across the country. So while, here in Colorado, we have a larger catchment area, there's a wide number of clinics. I think, I'm not sure of the total number, but Dr. T might know currently, because it seems like it's growing every time I turn around. But there's a lot of clinics and expertise across the country, especially knowing that this is an inherited condition. And so while we might be seeing a patient in Colorado, they often have extended relatives that need genetic counseling and testing and more information outside of Colorado as well. And with that, I think we will take some questions that you all may have. Thank you very much for listening today.
I don't see any specific questions in the chat. People can, I think, unmute or type them in the chat if they do have questions. Or if not, we just described everything so perfectly. Okay, well, everyone knows where to find us at Children's Hospital. If there's any questions about Fragile X syndrome, if you are a provider, if you are a community organization, or if you are a family. So just reach out, and thanks for having us.